In this section, we'll be discussing individual drugs that are injectable, but don't belong to the barbiturate or dissociative anesthetic category. They have unique structures and a completely different set of characteristics that determine their use in the clinic. Propofol, Diprivan, is a ring structure much like the previous drugs. It's a 2,6-diisopropyl-phenyl, making it an oil at room temperature. The actual drug is supplied as a 1% emulsion for IV use. An emulsion is just the physical mixture of an oil and an aqueous phase, not a true solution. So it's a white, milky liquid, often referred to as milk of amnesia, based on its tendency to induce amnesia as well as anesthesia. There's an aqueous solution of the drug in Europe, but it's not yet available here. Unlike barbiturates, propofol is infused continuously to induce and then maintain anesthesia. When it's injected, there's a rapid onset of action. So it's used as an induction agent, pretty much replacing the use of thiopental, whose effect wears off less smoothly. After the infusion of propofol is terminated, there's a rapid and smooth emergence from anesthesia, mirroring the induction. There may be pain at the site of injection, but no tissue sloughing. It's useful in combination with opioids, nitrous oxide, and inhalant anesthetics that can be used to extend the anesthetic episode after induction. Propofol is not readily absorbed and has to be given intravenously. Because it's so lipophilic, it's highly protein-bound in the circulation and enters the brain rapidly. It also exits quickly, like the redistribution of ultra-short-acting barbiturates. While it's metabolized rapidly by glucuronidation in the liver, it's probably a combination of metabolism and redistribution from the brain back to the blood that terminates its anesthetic effect. Like the barbiturates, propofol increases GABA-A activity. It interacts with a site distinct from either the barbiturates, the alcohols, the inhalant anesthetics, or the benzodiazepines. It acts to decrease desensitization of the GABA channel, so the inhibitory effect produced by endogenously released GABA persists longer than usual. Like barbiturates, propofol decreases blood pressure and cardiac output. It also causes a transient apnea, the problem that may have caused Michael Jackson's death. It decreases cerebral blood flow, so it's relatively safe for cases of head trauma where intracranial pressure is a concern, but it may lead to other complications. Propofol may be associated with a rough recovery in some dogs with myoclonic twitching and limb paddling. And repeated infusions lead to oxidative damage to erythrocytes in cats and anorexia and malaise. The biggest problem with propofol is the propofol infusion syndrome. The incidence of this is rare, but it's often fatal. There seems to be a priming effect that's necessary to produce this effect. It's either CNS damage, sepsis, burns, trauma, or pancreatitis. All of these produce endotoxemia, a condition that's associated with enhanced release of glucocorticoids and catecholamines due to the activation of the sympathetic nervous system. Glucocorticoids lead to skeletal muscle changes that induce myopathy and rhabdomyolysis, leading to renal failure. Catecholamines produce cardiac damage, leading to heart failure, shock, metabolic acidosis, and eventually renal failure. High doses of propofol alone inhibit mitochondria, increase free fatty acids, and induce arrhythmias. Once started, these reactions together are hard to stop and usually result in death, so it's essential to avoid using propofol in cases of endotoxemia and that can be caused by burns or trauma, and in cases of pancreatitis. The next drug is etomidate or amidate. It's a carboxylated imidazole that produces a short-acting anesthetic episode, so it's used as an induction agent or for very short procedures. It also produces amnesia, but it has no analgesic activity. Like barbiturates and propofol, etomidate acts by increasing GABA-A activity, binding to the beta-3 subunit, supports anesthesia, and to the beta-2 subunit supports sedation. Etomidate is very lipid soluble, so it's highly protein bound in the circulation. Although it's metabolized rapidly in the liver and plasma by esterases, it's the redistribution from the brain that probably terminates its anesthetic action, just like the ultra-short-acting barbiturates. Etomidate is generally quite safe, so it's used a lot in the emergency room where an extensive history of the animal can't be determined or where there's a lot of tissue damage and the animal's at risk. It has a high therapeutic ratio. That is, the lethal dose is about 30 times the effective dose, much higher than most anesthetic compounds. It has a rapid onset of action with a low cardiovascular risk. That is, there's less decrease in blood pressure than the other anesthetics, except of course ketamine, which actually increases blood pressure. There's also less tendency to be arrhythmogenic or to enhance the arrhythmogenic effect of catecholamines. The effect of etomidate can be antagonized by flumazenil, the benzodiazepine antagonist. This is notable because most of the other anesthetics don't have a specific pharmacologic antagonist. So this is another aspect of its safety, but it also suggests a unique mechanism of its action, that is, via a benzodiazepine receptor, which usually don't produce anesthesia when activated by other drugs like Valium. One major problem with etomidate is that it suppresses steroid synthesis in the adrenal, causing adrenal insufficiency. It does this by inhibiting 11-beta hydroxylase, the rate-limiting enzyme in the synthesis of glucuronides. So you need to treat the animal with hydrocortisone or the equivalent prior to the use of this drug, especially in light of the fact that these drugs are usually used in situations that are highly stressful to the animal, like the surgery itself, where steroids are essential to survival. Another problem with etomidate is that it may produce some seizure-like activity during induction. There may also be pain at the site of injection, and post-operative vomiting is quite common. Alfaxolone, or Alfaxon, is a relatively new injectable anesthetic. It's approved in cats and dogs to induce anesthesia as well as to maintain it by additional periodic infusions of a fraction of the inducing dose. Alternatively, it's safe to follow it with an inhalant anesthetic. The therapeutic index is high, and high doses are not lethal if the animal is sufficiently ventilated, preferably with oxygen. Even when used daily, it seems to have stable and reproducible effects. That is, there's no tolerance and no cumulative side effects. It's safe in kittens and pups, as well as greyhounds, which you may remember responded poorly to thiopental. Alfaxolone is a neuroactive steroid. It's an analog of the hormone progesterone, which is also closely related to cholesterol, mineralocorticoids, and glucocorticoids. But it lacks these hormonal actions. Instead, it acts by enhancing GABA-A channel activity, like barbiturates, increasing the chloride flux in hyperpolarizing cells. It may also inhibit by its action at centrally located glycine receptors. When you use alfaxolone, you need to inject it very slowly over a 60-second interval or more. The anesthetic effect lasts longer in cats, about 25 minutes, than in dogs, which is about 10 minutes. It's recommended to intubate when the animal is fully anesthetized and not before, due to the possibility of bronchospasms. You can use this drug to maintain the anesthetic episode, but the animal does recover very rapidly when it's terminated, so it's important to use the recommended dosage for maintenance rather than simply titrating to effect, because the animal might awaken completely if you wait too long to re-administer. As with most anesthetics, you also need to adjust the dose when it's used after injection of a sedative. There's minimal cardiovascular inhibition, but apnea may occur. Oxygen is recommended with the use of this drug and during recovery. There's a lot of information to master in pharmacology, and lots of it simply has to be memorized to be useful. When memory is consolidated, you can usually recognize the material when you see it again, for example, on a multiple choice test. But in the clinic, you need to be able to retrieve information from your memory in order to use it. An example of this is when you learn a new language. Consolidation of the words allows you to read a foreign language and understand it because you recognize the words when they're presented. But rapid retrieval of these words is necessary to speak that language. Merely reviewing or reading new material only allows you to consolidate it and recognize it when you see it. The best way to learn the information in a way that will allow you to use it is to test yourself. Repeatedly testing yourself forces you to practice retrieving it, so you can do this in the clinic and when you take your boards. So how do you test yourself? We've covered a wide variety of compounds, but they're all used for a similar purpose, to induce anesthesia as rapidly as possible by injecting them intravenously. Some can be used to maintain the anesthesia, some can't. Test yourself by comparing and contrasting this new information. Make tables like this that compare specific characteristics, like how they're used to induce anesthesia and what happens when they're used to maintain anesthesia. If you don't remember something, look it up in the drug insert to have the information reinforced using a new context and a slightly different description. Then test yourself again. This table compares the effects of these drugs on cardiovascular and respiratory function, as well as their unique side effects. Again, see how much you can fill in the table on your own before looking up the correct answers. Then try it again. Create new tables with information from drug inserts about the species that are approved for the drug compared to species frequently administered on an off-label basis. The more detailed these tables become, the more useful they'll be when you take anesthesiology. At that time, the clinical use of these compounds in a variety of pathological conditions will be superimposed on this basic pharmacology. In the next module, we'll be discussing inhalant anesthetics that are often used following the injection of these compounds to prolong the anesthetic episode. We'll see you then.